Hi, welcome to Crisis Prevention and Intervention Plan Training. I'm Lisa Bunting. I'm a licensed clinical social worker, and I'll be your trainer for today. Our learning objectives today are: what is a crisis plan and who should receive it, why crisis plans are important, who should have access to the plan, essential values and principles, steps to writing the crisis plan, and advantages to collaboration and partnering. Let's get started. Why crisis response training? It is our responsibility as treatment professionals, when we have clients who have mental health, intellectual developmental disabilities, and substance abuse diagnosis, to handle crisis effectively and efficiently. What is a crisis? A crisis can be two things. One is a perception of a crisis. A client can perceive anything as a crisis or a threat to themselves. A professional may have an opinion that a person is an immediate threat to themselves or others. The three parts to a crisis: first, there's a trigger or a precipitating event, the perception of that trigger, and when a client tries to use their normal coping mechanisms, that can sometimes fail and lead to a crisis. It's important for us to document with the client and their support system what that client's usual coping mechanisms are, such as taking a walk, calling a friend, walking the dog, taking a bath. That would be documented in the crisis plan. There are 5 phases to crisis. If we look at the 5 phases, phase 1 is prevention, early intervention, acute intervention, crisis treatment, recovery, and reintegration. I want to draw your attention to the 5th phase, which is the reintegration of a client after a crisis has occurred. It's going to be important for us to document not only how we're managing a crisis, but what we're doing after the crisis has occurred. When we're talking about the 5 phases, it's important for us to look at the plan and document those 5 phases, but do it in a person-centered way. We're looking at people's strengths, gifts, talents. We're talking in an empathetic manner, with treating them with respect. Let's think about this. If we have a client who has a strength of communication, we want to be able to use that strength when we're helping them get through a crisis. It's important for us to tie in the first page of a person-centered plan where we ask clients, what are your strengths? What are your preferences? It's important for us to then transition that to the crisis plan and actually use those strengths and preferences. Let's take a look at what a crisis plan is. A crisis plan gives us the necessary information that we need to respond to a client in crisis. It helps us plan for not only what to do during the crisis, but what to do after the crisis. Why are crisis plans important? They provide us a comprehensive document that gives us prevention, response, and recovery. They can also reduce cost, as well as keeping the client in the least restrictive environment. Let's talk about what the professional must do in terms of planning. We must plan for what the client thinks is a crisis, as well as what a professional knows when a person is an immediate threat to themselves or others. It's important for us on the crisis plan to span the crisis continuum when we're planning, from least restrictive to most restrictive. For example, if someone's strength is that they are a good communicator, their first step may be to call a friend. Their second step may be to take a walk. And as we go up the continuum, we start calling for professional help and eventually would call 911 if needed. Who should receive a crisis plan? There are 2 types of crisis plans: the person-centered one-page crisis plan and a new comprehensive crisis plan. The one-page crisis plan will still be required for individuals who received enhanced services and are not deemed to be at higher risk. The comprehensive plan, and we will talk about the criteria here in a minute, is going to be required for those folks who are at higher risk of having a crisis. Let's take a look at the standard crisis plan. You'll notice in the first box of the standard crisis plan, it talks about what are the client's triggers and behaviors. Let's talk about some ideas that you might be able to put when you're planning for the standard crisis plan in box number 1. We're going to talk about what triggers there are. There could be environmental triggers, there could be social triggers, medical triggers, and interpersonal triggers. For example, an interpersonal trigger may be someone who's feeling lonely. That may be a trigger for them that has a perception that could then turn into a crisis. An environmental trigger could be things like noise levels, crowds, lighting, that sort of thing would be notated in box number 1. Along with the trigger, then we're then going to put the client's behavior that happens when that trigger occurs. So if we take a look at if noise is a trigger for a client, we then may write down that they start to get agitated and they may start to sweat. There may be physical or cognitive changes. Those would be notated in box number 1. Let's take a look at box number 2. Box number 2 talks about preventative strategies. When we're talking about working with clients, some of the best people to ask about preventative strategies would be those support folks for people who are working with clients, family members, parishioners, school personnel. Those folks are going to be able to tell us what are the preventative things that we can be doing to help a person not go into crisis. If we look at box number 3 of the standard crisis plan asks us to talk about the steps that we are going to use to de-escalate a situation that could potentially become a crisis. Earlier, we talked about going from least restrictive to most restrictive. And so in box number 3 of the standard plan, we are going to list those steps from least restrictive to most restrictive. Some may decide to actually have the steps separate for the client versus the staff that are working for the client. Step number 1 for a client may be, I'm going to call a friend, I'm going to take my dog for a walk. Step number 1 for a staff member may be to use a calm voice, to make sure that people have enough space. Those may be de-escalation techniques identified for staff. Box number 4 of the standard plan asks us to write down the numbers of emergency contacts and personnel and people that are close to the client that need to be notified in a crisis. And if we look at the last box on the standard crisis plan, it talks about what are we going to do when the person is actually in a crisis, and then what are we going to do after it. So this is the opportunity for us to talk about the person is actually at risk of harming themselves or others. What does somebody who does not know the client need to know in order to best serve them? Then, once the crisis is de-escalated, we're going to talk about what's the next step. Be sure in box number 5 to talk about what's the next step. After the client, after the incident is done, what do we do next? Great. Let's go back and back to our PowerPoint. And you'll notice that there are a couple of slides for you to take a look at, that the Records and Documentation Manual takes a look at certain things that must be in a crisis plan. That Records Management and Documentation Manual lists for you the specific items that need to be in a crisis plan, such as supports and interventions, strategies for crisis response, strategies for follow-up that we just mentioned, contact, advanced directives, etc. Communication Bulletin number 139 identifies the new comprehensive plan that goes into effect January 1 of 2014. The new comprehensive plan criteria is also notated in the handout that you have downloaded that talks about what are the high-risk populations that need this new comprehensive plan. Let's take a look. For those of you who serve children, the child mental health part, or the child mental health diagnosis that are considered part of the high-risk population are diagnosis, and they are listed there for you, 293 to 297. It goes down to talk about 313.81 to 313.89. These are going to be diagnoses for kids such as psychosis, anxiety, oppositional defiant disorder, conduct disorder, eating disorders. Along with the diagnosis, you'll notice that they also have to have a Cal Locus level of 6. So we're combining not only a diagnostic criteria for the comprehensive plan, but we're also taking a look at the Cal Locus level as well. There's an added criteria for for children with mental health or substance abuse diagnosis who have been discharged from a facility within the past 30 days. So they can have these diagnoses, or they can have been discharged from a facility in the past 30 days. For those of you who serve adult clients with mental health diagnosis, you'll notice the diagnostic ranges for the criteria for the comprehensive crisis plan, 295 to 295.99, etc. We're talking about diagnoses such as schizophrenia, schizoaffective disorder, bipolar, PTSD. Along with that diagnosis comes a locus level of 6 for adults. For those of you who serve substance abuse clients, there are certain criteria that your substance abuse clients have to meet in order for you to use the comprehensive plan. Let's take a look at those. The substance abuse non-opioid dependent criteria has that criteria along with the ASAM level. The opioid dependent have that along with a history of use of injection within the past 30 days. If you serve folks, and many of us do, that have co-occurring diagnosis, the following are considered the criteria for the comprehensive plan. They have both a mental health and a substance abuse diagnosis, a CAL locus or a locus of 5 or higher, or an ASAM level of 3.5 or higher. For those of you who serve intellectual developmental disabilities, this comprehensive plan is only for those of you who serve folks that are not on the waiver. So let's take a look at, for those of you who are serving IDD clients, the individuals must have been referred or discharged from NC START, discharged from a developmental center, or have had 2 unplanned restraints in 1 quarter. In addition to all of the previous criteria we just talked about, there are 3 additional criteria we need to look at to identify high-risk individuals. The first is that a client or an enrollee does not appear for a scheduled appointment and they're at risk. The second is someone who shows up for their first service as a crisis. It's the very first time you meet them, that is how you are introduced. They would be eligible and considered a high-risk individual. The third is that if somebody has been recently discharged from an inpatient hospital or a PRTF or a facility-based, they are at risk, therefore need the new comprehensive plan. Let's take a look at the new comprehensive plan together. So let's take a look at the new comprehensive crisis plan together. You'll notice on the first page, it asks for demographic information at the top. It talks about some cultural considerations that we take into consideration in the middle in terms of communication. We'll talk about insurance and diagnosis. I want to draw your attention to medications. It's going to be important that we keep the current medications up to date on this plan. Things change, and we need to keep up with this because this can be helpful when we're responding to a crisis. On the second page of the comprehensive crisis plan, it talks about the supports for the individual. And it's important for us to take a look at all of the folks that are going to need access to this crisis plan. Guardians, families, residential programs, hospitals, physicians, and anyone else that would be needing this information to help the client during a crisis. On the last page of the new crisis plan, it talks about general characteristics and preferences. It's important for us to consider all of the cognitive and emotional triggers and behaviors that we talked about on the standard plan, but we're going to enhance that information and make it more specific to the person that we're working with. Let's take a look at an example here. In box number 1 on the comprehensive crisis plan, it talks about what I am like when I'm not feeling well. So we will describe the person right as if you are writing to someone who has never met the client before. Sometimes we are helping people in crisis that we have never met, and the more information, the better. So that first box may talk about when I'm not feeling well, I may be stressed, you may see it in my shoulders, I may be sweating, I may have a clenched fist. This is giving people an idea that the person is possibly moving into a crisis. The second box moves us right along that continuum into the early signs that I'm not doing well, and then we're going to move into what can others do to help me when I'm not doing well. Again, it's important for us to talk to family members, support staff, anyone that has interaction that could be helpful in de-escalating the situation. I want to note that something important has been added in the comprehensive plan, that it asks the client, what can a client do to help themselves? We're moving toward a partnership in crisis response versus throwing services at a client, having them participate in the process. So if we look at this box, it's going to be important that we plan when people are well. We ask when people are well, what can we do to help you? And we document that on the comprehensive plan. And then if you look at the last box, it talks about what has worked in the past and what hasn't worked in the past. I want to add, make sure that this is kept up to date too. The crisis plan is a living document that as the person grows and changes, we keep the information up to date. As we're writing both the standard and the comprehensive plan, let's talk about some considerations that we must take a look at when we're responding and looking at the crisis plan. We need to look at someone's history. Do they have a history of suicidal or homicidal attempts? What has worked in the past? What hasn't worked in the past? What are some risk factors? What do we know are some triggers that we need to consider when we're talking with people when they're in crisis? As we're writing the comprehensive crisis plan, let's talk about some considerations that we have to think about when we're writing it. Let's list 8. Why don't you take a moment and write down a few things that you know as a professional you need to consider when you're writing a crisis plan. Things we need to consider are history. Does the person have a history of hurting themselves or other people? Do they have a history of using substances? Do they have any risk factors that we need to know about in terms of any medical conditions that can exacerbate a crisis? What are some others? Maybe duty to warn. Are there any advance directives that we need to know? Do we need to pursue the magistrate in terms of an involuntary commitment? These are all things we need to consider when we're planning and writing the crisis plan. Who should have access to the comprehensive and standard crisis plans? It's important for us to include the client and their family in the planning process. Therefore, they'll receive a copy of it. But let's take a look at who else can receive a copy of it. Medical professionals, other providers, hospitals, mobile crisis. We are only as good as the crisis plans if people have them. So the idea is we need to get consent and get the people who need them the crisis plans so that we can utilize them. What are some final thoughts and some final questions we can talk about in terms of our standard, both standard and crisis plan? Is there truly enough information on that plan to help us manage a crisis? Be careful not to use cookie-cutter crisis plans where we'll use the same techniques for one person as we use for another. We know that everyone is different. Some people count to 10, some people don't. And let's make sure that our plans reflect that a person is an individual with individual needs and preferences. Another key thing to remember about your plans is that they need to be up to date. I know I mentioned it in terms of medications, but people move and phone numbers change and people move and relationships change where one person was a support and now they're not a support. So we want to make sure that the plan itself is up to date. How often do you think we should be updating the plan? I hope that we will update it as much as necessary, but I want to encourage you to take a look at both crisis plans, no matter what plan you're using, at least once a month to make sure that the plan is up to date. Now that we've talked about crisis prevention and planning, let's move into crisis response. Goals of crisis response are safety and security, ventilation and validation, prediction and preparation, rehearsal and reassurance, and education and expertise. As professionals, we should embody certain values and principles when we assist someone during a crisis. Some of those values and principles are assessing trauma, treating the whole person, making sure that somebody's safe, avoiding harm, and just treating the person with respect. What are some guiding principles in crisis response? Some guiding principles in crisis response are that people have access to care, and that access to the care is done in a timely manner, that people's rights are respected, that people's strengths and values and preferences are used in the plan, and that the treatment professionals are competent in crisis response. You can see a list of the values and principles on the attached required core elements sheet. Let's talk about the first responder. Who is the first responder? The first responder is identified on both the standard plan and the comprehensive plan. They're the person that responds first. So who are they? They can be a person and or an agency that is available 24/7, 365 days a year. When there are multiple providers with a client, we need to discuss and document who is the first responder. What are some responsibilities of a first responder? A number one responsibility of a first responder is to be available and to answer the phone. It sounds funny, but we have first responders that wait to answer the phone. So first responders answer the phone. They have time allotted and available to manage a crisis. They have childcare worked out. They have gas in their car. They have their phone charged. There's lots of things that go into being a first responder and someone who's on call. A first responder or an on-call personnel may carry around a notebook or have something electronic that has identified clients and their crisis plans on them. They may have other screening and assessment tools and resources in that notebook as well. A good first responder is prepared. What are 10 essential first responder skills? One may be communication, both verbal and nonverbal. Good questioning skills, the ability to elicit information from people. Good conflict management skills, cultural competence. They know resources. They know who's available and who to call and when to call them. They assure that someone is safe and they keep others safe around them. Can you think of any others? Take a moment and write them down. What is the response timeline for responding to a crisis? It will be important for you to take a look at your agency's policy and procedure manual to know what are the identified timelines that they have agreed to when responding to a crisis. Is it emergent, urgent, or routine? When you respond to a crisis, there are two parts to the response. First is the screening, the second is the assessment. So let's talk first about the screening. A good screening talks about where is the client and what's happening right now before we make any decisions. I want you to think about when you're screening a crisis, think about a 911 operator. A 911 operator asks certain questions: where are you? Who's with you? What's going on? Later, we'll assess the issue, but let's first talk about screening and make sure that we've properly screened before we move on. Take a look at the slides in front of you where it talks about a screening tool example. We may identify the time of the call, the name of the caller, and what was said. There are 5 questions that I would ask. What number are you calling from? Where are you? Are you alone? Do you have any thoughts of harming yourself or others? Do you have the means to do that right now? And have you taken any substances? After you've written that down on the screening tool, then you can take a moment and write the outcome down of what happened with that screening. Did you have to call for help or not? Once someone is screened, then we move into an assessment process. There are lots of different assessment tools that you can use. There's homicidal assessments, suicidal assessments, domestic violence assessments. A basic assessment usually answers about 6 questions when you're talking with the client. You're going to define the problem in the assessment. What's going on and what's the issue? The second part of the assessment would be, is there safety involved, ensuring that the client and people around them are safe? Third is to provide support and get support. 4 is to talk about what are the alternatives, what are the ideas that we can do to de-escalate the situation. The 5th is to actually make the plan for the assessment and make a plan for the crisis. And then at the 6th step is to obtain commitment from those involved to make sure that the crisis response happens. Again, I want to encourage you to get specific training on specific assessments such as homicidal assessments and suicidal assessments. We've talked today about talking about prevention and planning and response. And I hope that we realize that the more we work together in that, the better the response is going to be. So collaboration and partnerships are really important in effective crisis response. Partnerships allow us to work together, decrease stress and cost, as well as improve and extend natural and support networks for the client. Lastly, I want to point your attention to making sure that you have community resources available to you when you're responding to a crisis. Know your local resources of shelters and food and crisis response numbers, both locally and nationally, to help in your crisis response. Thanks for participating in today's training. Please take a moment to fill out your evaluation, and I look forward to seeing you at a future training.